This is chapter 15, the shock portion of the chapter. So the definition of shock, or hypoperfusion, is the inadequate perfusion to the tissues as well as the lack of removal of waste products as well. So first scenario, we have this elderly female. She fell in the shower, striking her head. She's a cut to the back of her head. About an hour after she fell, she couldn't stop the bleeding. She called 911. Vital signs: she has a rapid pulse. She's breathing fairly normally. Blood pressure is 116/80, probably a little low for someone of her age. Her skins are pale, cool, and moist, so that means she's probably releasing some epinephrine, so it's probably in some stage of shock here. So she's been losing whole red blood from the laceration to the back of her head. She is in what's called hemorrhagic hypovolemic shock. And this is when the person loses whole red blood. So it's kind of a twofold problem. One, they're losing volume of blood, which drops their blood pressure, but they're also losing their ability to carry oxygen in whatever blood they have left in their system. So the cure for this, obviously, is to stop the bleeding, if possible, and to get them to the hospital and to have them treated with whole red blood to replace whatever they might have lost, if the loss was significant. On the other side of all of this, you have what's called non-hemorrhagic hypovolemic shock. And this person still can have low blood pressure. They can still respond in a similar way when it comes to vital signs anyway, because this is hypovolemic shock because they are losing fluids. The difference is, of course, is they're not losing whole red blood. They're losing plasma and plasma proteins and water and fluids and ions. This is primarily from diarrhea, vomiting, dehydration, and sometimes even burns as well if they're severe enough. So they have the components of the blood in their system, just not enough liquid to circulate it effectively, causing their blood pressure to drop, of course. Treatment for this primarily is going to be going to the hospital, stopping what's causing the diarrhea, stopping what's causing the dehydration, and then rehydrating them with fluids by IV. Next scenario, this young gentleman was trapped in a house fire after his oven exploded. He was removed by firefighters. You find him lying on the grass. These are his vital signs. He's got a weak, rapid pulse, which might indicate possibly low blood pressure, which in fact you can see it is, 88 by palpation. He's got bilateral wheezes. His oxygen saturations are a little low, so you're going to put him on high flow O2 at 15 liters per minute. This probably would not be a good time to use a nasal cannula because we're not concerned about free radical release. We're not concerned about vasoconstrictive properties. This person's been in a fire. They more than likely have inhaled gas, smoke, heat, fire, and I'm very concerned about their lungs being damaged. They need to have maximized oxygen levels, the best we can get up to anyway. So some type of high flow oxygen would be appropriate. He's disoriented, and you notice your secondary assessment shows he has approximately 40% burn surface area to his body. Now, when it comes to what's called burn shock, which is caused by the burns themselves, if you think about the mechanism of burn shock, where the thermal energy of the heat from the fire or the flame penetrates the skin, and it damages the capillary beds in the dermal layer of the skin. The capillary beds become, or the capillaries themselves become, they start to leak out, and they start leaking out plasma. This process takes a while. So if someone is critically burned, it might take them hours, 6, 8, 10, even 12 hours before their blood pressure would start dropping. So if you arrive on scene to a house fire and the patient has just been injured or just been burned within the last 15, 20 minutes or so, and they're presenting like this with low blood pressure and high heart rate and all that, you can almost guarantee that their state of shock is not because of the burns. It's because of possibly the explosion caused internal injuries like a ruptured spleen or a lacerated liver, and they're bleeding internally. So they're actually in hemorrhagic hypovolemic shock. So burn shock is, it depends who you talk to really, but a burn shock is a form of distributive shock, and that's somewhat controversial, but it does affect the capillaries. It causes them to dilate, to leak out. So you can include that probably in that particular classification of shock. So you can see this gentleman right here. He, I believe this was an electrician who got zapped by very high voltage. That what appears to be a glove on his hand is actually the skin of his hand peeling away due to the intensity of the burn. So this person, that energy has penetrated his skin, and again, it's that leaking plasma is causing his low blood pressure. This very seldom usually happens here in the field or out in the field, because normally these patients are very rapidly transported to a burn center. They're given tons and tons of fluids intravenously there to help to make sure they don't go into burn shock. But if someone is seriously burned and for some reason they're not seen or gotten to within time, hours and hours and hours later, you might see this. It's pretty rare. This person right here, he was stung by a bee while at the county fair. Heart rate is as expected. It's 134. It's weak and regular. His breathing is labored. He's got wheezes and stridorous sounds. He's got stridor in the upper in the throat, and wheezes in the lungs. Blood pressure is low. He's a little slow to respond due to the hypoxia. You can see the itches and the hives, and also he has what's called angioedema. And that face in the picture right there, all that swelling, the swelling to the lips, the cheeks, around the eyes, the tongue, that's all caused by or called angioedema. And this is the case where because he's been stung by the bee, and because his body's releasing histamines that's reacting to the bee sting, it causes the capillaries to leak, and it leads to swelling to the tongue, the throat, the face. Anytime you see someone who's been stung by a bee or in any way is having some kind of allergic reaction, if you see swelling to the face, around the eyes, the lips, the tongue, the throat, it's automatically would be considered to be a fairly serious or quite serious allergic reaction, no matter what their blood pressure is, no matter what the respiratory status is, because it's probably going to develop into something worse. This person does need epinephrine. And this is another form of distributive shock, because the anaphylaxis, the histamines that are released cause vasodilation of the blood vessels. And when the blood vessels dilate, the container gets bigger, though the blood volume remains the same, so it drops the pressure in those vessels. So essentially, as the blood vessels dilate, it gets harder and harder for the body to distribute this blood around the body and to keep circulating, because the pressures drop so much. The volume is the same, the heart's still pumping away, but the blood vessels have just massively dilated, dropping the blood pressure. And you already know the treatment for this is epinephrine IM, either 0.3 milligrams for adults or 0.15 for pediatrics. And of course, oxygenation, rapid transport to the hospital. This little old lady, she lives at a skilled nursing facility, a SNF. She has altered mental status today. That's why you're called. She's normally awake and alert. She is now non-ambulatory due to a previous stroke, and she has a Foley catheter in place. There's a urinary catheter in place. Fairly indicative. You get these people with urinary catheters, they are prone to infections. Rapid pulse, weak pulse, labored respirations, blood pressure 128/90. Might be a little low for her age, might be average, not anything significant there. She does have bronchi in the lungs, probably has some mucus in her lungs, some infection going on in her lungs. Your APU, when you do a trap squeeze, she moans to pain. Skins are hot, moist, and pale. Temperature is obviously elevated. So you can tell by all this she probably has some kind of infection, and this is known as septic shock. It can happen for a number of reasons. The most common is a urinary tract infection that develops into a kidney infection, which then spreads to the rest of the body. And it's very common in people who have Foley catheters in place, or elderly people who have diapers on, or depends on, I guess, if you want to call it that. And maybe because of their caregivers, they're not being changed often enough, and they develop a bladder infection, which spreads, and then finally they become septic. It is life-threatening. Eventually, it can cause the vasodilation of their blood vessels, which drops their blood pressure, just like with anaphylaxis. So this is another form of distributive shock. Treatment for this is really simply going to be rapid transport to the hospital, oxygenation, basically shock position, so lay them flat or supine on the gurney. They're going to be very hot to the touch, so they don't really need to be kept warm. Sometimes in the later phases of septic shock, towards the end of the process, their hypothalamus, their body's ability to maintain their body temperature gets skewed, and they start to become hypothermic. That high temperature, that 101 temperature that this lady has, if this isn't, if the doctors don't intervene, this person can drop into hypothermia and drop their temperature. So you get to these facilities. This woman's deeply into septic shock. You feel her skin; she's cold to the touch. Her body temperature is 96.2, really low. So you're thinking, oh, she's hypothermic. She's was exposed to some kind of cold temperatures, but in reality, she is septic. If you listen to the story about how this progressed by the caregivers, again, the treatment for this is rapid transport to the hospital. They're going to provide her with lots of fluids at the hospital intravenously, as well as antibiotics to treat whatever bacteria they might have. This gentleman, he was a construction worker. He fell 20 feet from a scaffolding laying down to his back. His pulse is 46, weak and regular at the carotid site. You cannot feel a radial pulse. His breathing is 8 and with poor tidal volume. His saturations are really low. You cannot obtain a blood pressure. He's unresponsive completely, and his skins are flush, warm, and dry. So this person is in shock. The reason why he's not presenting the way you would normally think about a shocky patient. His skins aren't pale, cool, and diaphoretic. His heart rate's not rapid. His breathing's not rapid. Is because this is another form of the distributive shocks. This is a neurogenic shock. Now, with neurogenic shock, what's happened is the spinal cord has been traumatized. More than likely, it's been severed somewhere in the cervical area of your spinal column, and there's no innervation. There's no more messages coming from the brainstem down into the body, so the body cannot release adrenaline and cannot compensate for what's going on. Also, there's no more innervation to tell the blood vessels to dilate or to constrict. So all of the blood vessels just dilate out. And again, you have this, this situation where you've got this really big container, which is the blood vessels, and the normal volume of blood, and that just drops the blood pressure. Treatment for this is rapid transport to a trauma center. This would be the kind of call where if you work close to medics, have medics rendezvous with you, they can give medications to artificially raise this person's blood pressure to keep them alive on the way to the hospital. Otherwise, go to the nearest trauma center. They'll do the same thing. They'll pump them full of medications to increase their blood pressure. And of course, they're only breathing at 8 times a minute, so you're going to be doing ventilations, more than likely bag valve mask ventilations, to maintain the respiratory effort. This is a little old person called 911 after a sudden onset of chest discomfort and shortness of breath. They have a slow, weak, irregular pulse. They have labored breathing with poor tidal volume, 92% on room air. So you're going to go with some oxygen on this definitely. Very low blood pressure, rales, crackles in the lungs. So we have maybe some left-sided heart failure going on as well. So this is cardiogenic shock. So this person, their shock is caused by the heart failing. Most common cause of this is a myocardial infarction, a heart attack. If someone does have heart failure, right-sided heart failure, I mentioned this before, I think during the A&P lecture, but people do get what's called pitting edema to the ankles. This is what it kind of looks like, swollen ankles, and if you go and push in with your finger, it creates a pit, leading to the term pitting edema, essentially. So what's happened, why this person is in shock, probably because he did have right-sided heart failure, or he does have right-sided heart failure, but it has now progressed into left-sided heart failure due to maybe now a heart attack, and now the heart can't pump effectively, and it can't keep up the blood pressure. So there was plenty of blood volume. The blood vessels are trying to compensate, but the heart just can't keep up. It can't pump effectively enough to keep the blood pressure up. And then, as the heart's been injured by this heart attack, it could possibly have affected the sinoatrial node, which causes that low heart rate that you're seeing on this patient. That's 40 beats per minute. The SA node is failing, causing that to happen. 2 other types of shock, obstructive shock. We haven't covered this just yet. We will in the respiratory lecture. But this is a pulmonary emboli. The definition of an emboli is a clot or other obstruction that's traveled from one part of the body and lodged somewhere else. Commonly, these blood clots can form in the legs, and they can travel up into the lungs and get lodged in an artery in the lung, and this is called a pulmonary emboli. And it's obstructive because if this clot's large enough, it obstructs fairly large arteries in the lungs, and it reduces or obstructs the blood flow through the lungs. And if there's less blood flow through the lungs, there's less blood flow into the right side of, the left side of the heart, and then that's the preload, like we've been talking about. And if you have less blood flow into the left side of the heart, there's less ejection of blood, and then there's less afterload. All basically drops their blood pressure due to this clot lodged somewhere in a large artery in their lungs. The other type is called metabolic shock, and this is purely due to severe hypoxia, usually respiratory based. This is the person with an oxygen saturation of 50, or 40, or whatever. Really, I've seen in the low 50s before, so it does happen. And as you already know, muscles need oxygen as well as glucose to function. This person doesn't have the oxygen. The blood vessels of the arteries and veins can no longer hold tension. They can't constrict, so they dilate out. So you get this low blood pressure because of the hypoxia. It's a really rare, I've only really seen it once in my entire career that I knew of anyway, but it can happen. So the body responds to all this. So if you're thinking about things like hemorrhagic shock, hypovolemic hemorrhagic shock, and we've been talking about this quite a bit already, the body releases adrenaline, it increases the heart rate, it increases the contractility of the heart, it causes vasoconstriction, thereby increasing the blood pressure by those two mechanisms. It also increases the rate and depth of respirations to get more air in, to get more oxygen down to the alveoli, to better exchange those gases. So the epinephrine is really there to keep us alive. But epinephrine is a finite resource. It only lasts so long. It only releases, so much. So there's a point where that compensation, that compensatory mechanism that our body has to keep us alive starts to fail. And once it starts to fail, we then go into what's called decompensated shock. So now there's not enough epi being released to keep the tone up on our veins and arteries, so they start to vasodilate. The heart isn't pumping quite as well because of that, and maybe we're still losing blood. So that's another, nail in the coffin, so to speak. And then eventually, if nothing changes and no one intercedes and with blood or stopping the bleeding or whatever this person needs, cells are going to start to die, and eventually you'll get organ failure from the cellular death. Now the MODS, it used to be called irreversible shock, but they've changed the definition. Now it's multiple organ dysfunction syndrome. Fancy words, those doctors, how the doctors are. So this is the poor person who's been through the compensated shock. They've been in the decompensated shock, and they haven't had it. No one's gone in and tried to stop the bleeding. Maybe they've been out in the field somewhere. No one's found them for a while, and now you have lysing of the cells in the organs, and the organs they're dying. The cells do not regenerate or reproduce. So eventually now what's going to happen, even if you get this person to the hospital alive, you treat him with high flow O2 and bag valve mask ventilations and keep them warm and rapid transport and maybe stop their bleeding if you can. They're so far gone into this MODS, they're probably going to die within hours or days of them getting to the hospital. So these people, they're already basically dead, even though they got a pulse. So you have this gentleman here. He's got stabbed in the lower left abdomen. He's awake and alert when you get there. He's anxious and agitated, and I would be too if I got stabbed in the abdomen. Blood pressure is fairly decent right now. It's kind of artificially elevated because of the epinephrine release. Both the systolic and diastolic have been raised up a bit above normal because of that vasoconstriction and the increased cardiac output. His pulse is not too bad. He's still compensating. His skins are pale, cool, and clammy, so based on those three findings that he is releasing some kind of epinephrine. You get him in the gurney or in the ambulance, and you got high flow 2 going. You're keeping him warm with a blanket. He's in his supine position, the shock position, basically. And you do your reassessment every 5 minutes. You're noticing that what's happening is the diastolic is remaining 90, but the upper number is dropping. So what's that telling you is that he still has some fairly decent vasoconstriction going on from the epinephrine, but he's still losing blood, and because of that, it's causing the upper number to narrow or drop down closer to the diastolic. Again, this is a sign of this person is going into or developing decompensated shock. Heart rate's coming up. Skins are cold to the touch. He's now diaphoretic, so he's dripping with sweat, and he's becoming confused, more agitated. So you can see he's kind of crumping at this point. Age considerations in shock. So we talked about this a few times already, I'm sure, but medications like blood thinners, beta blockers, they can decrease this older person's chance of survival because of their effects. So because of the fact they can't coagulate blood to stop their bone bleeding, and the beta blockers won't allow them to compensate for this shock that they're going into. So elderly people have a tendency to die more quickly because of their age, the aging process, and also the medication that they're on. Conversely, little people like this, they're young, they're healthy, they compensate really, really well, but they don't have much stores of oxygen and they don't have much stores of glucose. So they compensate really well and they suddenly kind of drop off the curve. They decompensate really, really quickly, right in front of you sometimes. They're stable at one point and 2-3 minutes later they're crumping and going into decompensated shock. So in both cases, well, with all cases, I guess, you would be dealing aggressively with these patients, treating them aggressively, trying to anticipate them going into decompensation and do everything you can to keep them out of it, if possible. So pretty straightforward. Make sure the ABCs are intact, oral pharyngeal airway, nasal pharyngeal airway, suctioning, those kinds of things you've already learned about. All these people I've talked about so far really need high flow oxygen. You try to keep that oxygen level above 94% in any way you can. Bag valve mask ventilations, non-rebreather mask, whatever it is. If you can get to the external bleeding, stop the bleeding. Apply tourniquets, direct pressure dressings and all that. Rapid transport to an appropriate hospital. If it's medically related, like cardiogenic shock, I would go to a STEMI center. If it has something to do with the neurogenic, like the broken neck, trauma center, those types of things, keep them warm. And if it is something like sepsis or neurogenic shock, if you're far away from the hospital and there is a paramedic unit, fire truck or ambulance closer, and it's somewhere along the route to the hospital, I would definitely rendezvous with the ALS, have them jump on your ambulance, and they can continue the treatment on the way to the hospital. So it wouldn't really delay more than for a couple of minutes. Otherwise, if they're way far away and you're closer to the hospital, you're closer to the trauma center, or whatever hospital you're going to, just transport rapidly, safely, of course, there. The quiz that's associated with the chapters 14, 15, 16, and 17, it does have some cardiac arrest questions in it. So I just wanted to get you to realize that, and so you won't be blindsided by them. So just some things like this. So just really common questions like downtime, how it affects the patient's outcome, when you use an AED, how you use it, common rhythms, and if you do get a pulse back on somebody who is in cardiac arrest, what do you do? So just something to think about when you're taking the test. And that's the end of our shock lecture. Happy times.